So what is a Spitz Nevi? Well, it was actually first described by Sophie Spitz, who was a pathologist at Memorial Hospital in New York City back in the 40s. She thought these lesions were all melanomas, but that they had indolent biologic behavior, and she called them actually benign juvenile melanoma, and she thought the histology was indistinguishable. It's interesting, she died before the term Spitz Nevi was created, so she never knew that this was an eponym in her name. And this is a photograph of Sophie Spitz. She was actually married to Dr. Arthur Allen, who was also an early dermatopathologist. There was a text he wrote called The Skin that was used for years, and this is her original article. It's called Melanomas of Childhood. So what is the definition of a Spitz Nevi? Well, it's a benign lesion with architectural features of symmetry, circumscription, predominant nesting, and maturation of spindle and or epithelioid cells. Really kind of needs to have all of those, or it may be something else. So that's a good definition of it. The thing that's sort of a problem about them is that they may have cytologic atypia, mitotic figure, and pagetoid spread. So those are the things that simulate melanoma, and these are the things that dermatopathologists have a difficult time with sometimes. Okay? These are not as uncommon. We normally, in our lab, every day, we see anywhere from 2 to 5, sometimes more on a daily basis. And they're also seen not only in children, about 40% are in adults. So these aren't just melanomas of, quote, childhood, they're also in adults. You can see features that we call, quote, Spitzoid in a lot of different settings. We already talked about spark nevus, so we'll talk about others. And this is, again, a known simulator melanoma that's medical legally charged. It's actually influenced medical practice with regard to diagnosis and treatment. So a situation where lawyers have driven us to treat these in certain ways, unfortunately, which isn't necessarily a good thing. These are some of the clinical features. I'll just show you some of these. So little small dome-shaped skin-colored papule on this little kiddo. Another one here. So hopefully this is more Spitz Nevi than you've ever seen in your life. That's the goal. Another example on this ear. 2 little Spitz Nevi on this little kid. An orange. These tend to be orange sometimes. So an orange lesion, dome-shaped, think of Spitz. Another one here. Sometimes they have kind of these little peau d'orange appearance, and that kind of correlates with the nests of epithelioid cells at the dermal junction. They can be heavily pigmented, be very, very dark, and people get worried about melanoma, but you can get heavily pigmented Spitz Nevi. They have a dome-shaped lesion. You have a little sort of a shoulder, so this might have histologically been one of those, quote, spark nevi we talked about before. They can be agminated, and you all remember that from the first lecture. Agminated means like a flock of sheep, so close together. And they can be widespread and disseminated. Sometimes they can occur in the background of a nevus spilus, where there's a macular hyperpigmentation, and all these Spitz Nevi occur in the center of that. This little kiddo had thousands of Spitz Nevi, trunk, extremities, all over his body. And actually, there was a paper published. Here he is again, a little bow tie, and another photograph of him. So this is when he's little, getting a little bit older now. He's getting close to pre-adolescence. And we actually have a photograph. He actually was followed for like 20 some odd years and was published in JAD. Never had a melanoma, living fine with these lesions. They haven't really caused any problem. A lot of histologic variants of Spitz Nevi as well, so I'll show you some of those. Junctional Spitz with spindle cell predominant. Okay, so mostly spindle cells. It is a nevus of spindle and or epithelioid cells. Again, relatively small, mostly nested. Some epidermal hyperplasia. Again, mostly spindle in this case. And some heavy pigmentation. A little bit of pagetoid spread, but we see that in these lesions. Does not mean it's melanoma. Junctional Spitz epithelioid cell predominant. So not as spindle, mostly epithelioid. Notice the pagetoid spread here. Again, totally benign. Some epidermal hyperplasia, hyperkeratosis. Camino bodies, dull pink globules in the epidermis, very helpful if you see those. An ugly mitotic figure, but still benign. Okay, pagetoid spread, still benign. It doesn't mean that it's melanoma. And if you see the caminos, that's really helpful. If you get a lot of lesions, I've never seen a melanoma with lots of camino bodies. And maybe 1 or 2 possibly, but not a lot. So again, camino bodies are really helpful. Acral Spitz Nevi, they can occur on palms and soles. So again, very, very well circumscribed, symmetrical, marked epidermal hyperplasia here. Again, epithelioid cells predominating. Again, some slight pagetoid spread. And another example of some cells in the granular cell area here, still benign, not melanoma. Adult Spitz Nevi, junctional type primarily. Very small, very symmetrical, very well circumscribed. Again, comprised of these epithelioid and spindle-shaped cells, more epithelioid than spindle. This one did not have very many cells above the junction. And again, no really mitotic figures or any of those kind of features, nothing that really would make you think of a melanoma. So again, I would not recommend re-excision of that lesion. I would just say, fine, Spitz's nevus. What's the oldest person I've seen a Spitz's nevus in? I've seen a Spitz's nevus in an 82-year-old person, and I did not recommend re-excision. He may have died before the lawyer came to roost, but but it was an obvious Spitz's nevus, and so a lot of people will have nevi and they leave him alone for many, many years and finally get a biopsy, so there's no reason you couldn't have a Spitz's nevus for most of your life. Another example of a lesion here. Again, this one almost looks like a wart. Again, very symmetrical, and these often come into us as warts, and this one's got mostly epithelioid cells here, epidermal hyperplasia, hypergranulosis cells and nests all the way into the granular cell layer. Again, a very small symmetrical lesion that's benign. This one had both spindle and epithelioid cells, more compound than junctional. Again, Spitz's nevus, and epidermal hyperplasia, hyperkeratosis, hypergranulosis. These are all classic features of Spitz's nevi, and this one did not have many pagetoid cells above the junction and has some caminobodies over here, but it did have a mitotic figure. So this does not mean that it's melanoma, and there's the caminobodies. Another compound, pigmented Spitz's nevus, so this one's very heavily pigmented. And some of these, when they especially get a lot of spindle-shaped cells, we call them the pigmented spindle cell tumor of Reed. But notice these cells, again, arranged mostly in nest, mostly at the junction. Lots of melanin here within these cells. Some of those are melanophages, some of the melanocytes. Again, this one's got some spindle-shaped cells here in these elongated fashion. Very common to see that sort of hands of banana appearance of nests of spindle cell melanocytes in Spitz's nevi. Another 47-year-old lady that had a Spitz's nevus. Again, notice it's very, very sharply circumscribed, quite symmetrical. Draw a line right down the middle and fold it over. So when we see that, it's really, for us, it's very, very suggestive of a benign process. And we sign these out every day. We don't recommend removal of all of these lesions. We don't send these to fish. We don't send them for testing. We can diagnose this just with H&E using criteria that I've already described to you. So again, you should be able to diagnose a Spitz's nevus with confidence. If you don't have confidence, you really have got a problem. So another example, and again, these occur in adults all the time. Again, this one's got prominent epidermal hyperplasia. This has got a little bit more inflammation. Cells arranged mostly in these nests here. And again, we see mostly nested lesions like this. Again, it strongly favors benign process. Very epithelioid, very, very few, if any, mitotic figures here. A Spitz's nevus in the dermis, a 49-year-old woman. So again, almost no epidermal involvement here. And again, it's a dome-shaped papule. Clinically was thought to be a nevus. High magnification, it's got the spindle and or epithelioid cells. This one did not have much of a dermal junction involvement. So this was a dermal-based Spitz's nevus. Again, benign. Now, something like this, if we don't have the whole thing and we can't apply all of the criteria, we might recommend re-excision of something like this just because we don't know for sure that this isn't a sample of something bigger and whatnot. So if we get something like that, that's a situation we might recommend re-excision. But this is a pretty classic example of a dermal-based epithelioid Spitz's nevus. And then the pigmented spindle cell tumor of Richard Reed, Dick Reed, a dermatopathologist in New Orleans, a good friend of mine for many years. Again, these show features similar to those that we've talked about before, but they're very heavily pigmented. And here you see the cells, again, arranged in these elongated nests, hands of bananas, if you will, so mostly epithelioid and spindle-shaped cells here. Some have more pigment than others. They may have a lot of pigment clinically, but histologically they don't necessarily have to have a lot of pigment. So again, and then sometimes you see lesions which there are two different features. We may see features of a blue nevus in one area and a Spitz's nevus in another area. We may see features of a regular banal compound nevus with a Spitz's nevus component to it. We've already talked about the combination of dysplastic nevus and Spitz's nevus. They look the same clinically, so you can't really tell them apart. This is purely a histologic finding. So again, you've got what areas that look almost like a congenital nevus over here, and then as you look at higher magnification, a lot of these cells are very epithelioid and heavily pigmented, and we sometimes refer to these lesions as pigmented epithelioid cell nevi or pigmented combined nevi with features of blue nevus as well. So again, this was a completely benign lesion. It was submitted to us in an excisional biopsy. And then there's a Spitz Nevi where you can get a sclerotic stroma, referred to as desmoplastic. Now, we've heard about desmoplastic melanoma. Desmos is the Greek word for tendon, so it basically means that these cells are kind of getting a sclerotic or fibrotic appearance. And it's not that there's really any fibrosis, it's that the individual melanocytes have got a sclerotic appearance. This was a woman on her back, and again, a punch biopsy, and you can see that it's got all of these nest of cells here, but as we go to higher magnification, you can see that they've developed, the spindle-shaped cells are beginning to kind of form fascicles, and it almost looks like a scar in some of these areas down here. So again, very benign appearing nevoid cell, so this is not a melanoma, but it does have that desmoplasia, and we do see that on occasion as well. This is an interesting variant where you get a Spitz Nevi where the cells are discohesive. Seen more commonly in children. These usually come into us as the diagnosis of wart or pyogenic granuloma. The cells kind of seem to fall apart. There's usually some atypia and occasional mitotic figures where they have prominent epidermal hyperplasia, another orange Spitz Nevi. So hopefully you've seen more Spitz Nevi already than you've seen in your entire career. Notice it looks like a wart. It's dome-shaped and papular. It's got verrucous epithelial hyperplasia. It's very symmetrical. It's very well circumscribed. It's small, so it's totally benign. And if you go to higher magnification, you can see these cells are kind of falling apart. They're discohesive, and this is one variant of a Spitz Nevi. Camino bodies in this nest of these epithelioid cells here. Dilated blood vessels, that's probably why they look kind of reddish or orange. And here's another example. Again, notice that it's very small. It looks polypoid. It looks like a wart. And again, these are just another variant of a Spitz Nevi. And now that we're beginning to do genetic studies on these variants of Spitz Nevi, my prediction is that we'll find some special type of gene abnormality here. And I'll show you some of those in a second that defines why this lesion looks the way it does, because it looks completely different than the other Spitz Nevi that we've already looked at this morning. Still benign, no reason to recommend excision on this. Now, you heard the term Spitzoid and Spitzian. You'll read these in reports, and they basically refer to a lesion that has some features of a Spitz Nevi, but not expressing all of those to really just call it a Spitz Nevi itself. So it's maybe, they're benign lesions, but they may have some epithelial or spindle-shaped cells, and may have some cytology that looks like a Spitz Nevi. So again, you'll hear this on pathology reports. So this is what we call compound nevus with, quote, Spitzoid features. Again, it's heavily pigmented. The cells are arranged in these round nests in some areas, but more kind of almost like a pigmented spindle cell tumor of Reed a little bit in some of these other areas. But these cells are a little bit smudgy. They're not really purely epithelioid or spindle exactly. This is from a 12-year-old kid. And again, we call this a compound nevus with Spitzoid features rather than just calling it a classic Spitz, because it does have some features of Spitz, but it's got some other features of a more banal nevus as well. This is melanin in the cornified layer, so you see that a lot with heavily pigmented lesions. It gets transepidermally eliminated. We've already talked about this. We don't need to really go over it a lot, but just realize it's out there, and sometimes you get that back as a report. Now, this is new. There are a number of Spitz Nevi that have been sort of shown to have specific genetic features, and they actually have clinical and histologic correlates that go with these. The first one of these is this BAP1 epithelioid nevus. And remember we talked about that 3p21 mutation last night in that case. Well, the BAP1, if you get this mutation, it's actually associated with the germline melanoma, but it can also occur in sporadic types in some of these epithelioid cell nevi. There's another one that's been called the so-called atypical Spitz tumor with 11p gain with or without an HRAS mutation. And then a new paper just published recently, Spitz Nevi with ALK fusions in them. So again, this BAP1 is seen commonly in uveal melanoma. These germline mutations is seen in familial melanoma. But if you look at this under the microscope, they have these large clones of these very, very large epithelioid cells. And a recent paper just published this month has shown that in a couple of more garden variety Spitz Nevi and blue nevus-like melanoma, you can see a BAP1 mutation sometimes. They usually don't have a lot of epidermal hyperplasia or camino bodies, no clefting, so they look a little bit different. So these are what some of those lesions look like clinically. They're these pink, they don't have a lot of clinical features, but histologically you get these large sheets of these very, very large epithelioid cells. They're totally benign. You usually see other areas within the nevus that look like a banal lesion, but you get these large, very epithelioid cells that are sort of present in islands within the lesion. So if you see this, it's not cancer. It just is one of these unusual variants that may be associated with this BAP1 mutation, interestingly enough. The sclerosing Spitz, or the desmoplastic Spitz Nevi, sometimes has now been shown to have this 11p gain or with or without this HRAS mutation. These tend to be larger lesions. They have this desmoplasia. The nests may become somewhat single near the base. Again, they didn't comment about clinical features in their paper, but this is what those lesions look like under the microscope. Again, the desmoplastic component. So if we were to go back and do a genetic study on that desmoplastic melanoma nevus I showed you before, it might have had an 11p gain in it. We don't know. We didn't do that, but it's just something interesting to know. And this paper published, again, very recently, Spitz's nevi and atypical Spitz lesions with ALK fusion. Well, what's going on here? Well, gene fusions are hybrid genes when you have two separate genes that kind of join together, either due to translocation or deletions or chromosomal inversions, and it may result in an oncogene. So what happens is you get these fusions, there's maybe a gene that's silent, it's not doing anything wrong, and suddenly you open up this oncogene or proto-oncogene that becomes active, and it can sometimes be seen in Spitz's nevi. Well, this paper, they actually looked at this protein, the ALK protein. They noted that there were other kinases. These are tyrosine kinases, and they noted that some of these were fused in these Spitzoid lesions and other kind of cancers as well. These generally, you'll have only one fusion. You won't have more than one. And it's sort of analogous to the mutations occurring in oncogenes that we find in other melanocytic lesions. So it's kind of an interesting thing. And this is what some of those lesions looked like in their paper. These people did not have melanoma. These were benign lesions. Again, it's small, symmetrical. And again, it just looks like a Spitz's nevis, but just happened to have this ALK fusion. They didn't really comment in the paper what the significance of it was, but it just goes to show you that we're studying a lot of these Spitzoid lesions now, looking at the genetics of them, which is kind of interesting. So how do we tell the difference between Spitz's nevis and melanoma? Well, again, this is classically one of the difficult things to diagnose in dermatopathology. Unfortunately, because it's medical legal, some clinicians routinely excise all of these, even in children, even in 2-month-olds and whatever. I don't like that. I think it's not good, but there was a paper that was published in the JAD a couple of years ago which said that virtually all dermatologists are re-excising these now. So I don't think it's a good thing to do. I think there are a lot of cases in younger children you don't necessarily need to do it. But I'm going to show you some examples where it's not so easy, and this is where we do recommend excision. So these are some of the features that favor benign over malignant. We've already talked about this. These are some of the features that favor melanoma over Spitz's nevis. If you see a Spitzoid lesion that's got mitoses near the base, necrosis of melanocytes, or a broad bottom, even if it's in a kid, you got to be concerned about melanoma. So broad fat base is bad in a Spitzoid lesion. Just remember that, okay? So in spite of all these great criteria we have, there's some that are still difficult. This is one that was in a 13-year-old young kid, and we usually favor Spitz's nevi in these situations, but today this would be a lesion we'd send off for genetic testing. It's got a broad base. It's pretty big. It's fairly, it's not strikingly asymmetrical, but it's got a lot of cells here, and it had mitotic figures. These are atypical. Again, this was of concern to us. So these are the kind of lesions we recommend excision, recommend sentinel lymph node biopsy, and today we send it off for genetic testing for additional information. I don't know whatever happened to this kid. I think it was excised. He never had a metastasis, so it was probably benign. But this shows you that they can be tough to diagnose in some cases. Okay, so here's a 35-year-old man. Again, we call this atypical Spitzoid melanocytic lesion, favored Spitzoid melanoma here. Again, it's pretty broad. Again, does not have a lot of pagetoid spread. It's got some nests up here in the epidermis, but it's big, it's broad, stuffing of these dermal papillae. Again, we see that. That's a feature that favors melanoma. Had a large mitotic figure here near the surface of the lesion. So we call this lesion melanoma. Another example, again, heavily pigmented, somewhat asymmetrical, but very Spitzoid in its morphology. So we favored Spitzoid melanoma in this case also. And these, again, are lesions that today, if we struggle with these, we're going to send these off for studies. So again, what's our general rule of thumb morphologically for diagnosing these? Well, in an adult, it's got to be perfect for Spitz's nevis, or it's more likely to be Spitzoid melanoma. And the reverse is true in a kid. And in some cases, again, we're just not sure. We recommend excision, and we send for other studies. Now, there are techniques that have been described in the literature using immunohistochemistry. I don't use immunohistochemistry a lot. I kind of agree with what Ella said yesterday. There's a lot of aberrant staining in these lesions, especially if this paper published just a couple of years ago, that if the lesion has been traumatized or treated with liquid nitrogen, even if it's a benign lesion, it stains like a melanoma. So I don't like using stains for this. There have been some case reports using nuclear P53, small study with a lot of overlap, and some people look for P16. You can look for BRAF mutations. Again, I think these are better for therapeutic than diagnostic purposes, but it's something you can do. It's been reported. Again, molecular studies, we're going to talk about that a little later on. I think this is the future of what we're going to be doing. And then we actually were the first ones to recommend doing sentinel lymph node adenectomy. The original recommendation was that the sentinel lymph node sheets of atypical cells means it's melanoma, but I think in some cases you can get a few cells that go to lymph node and it doesn't mean melanoma. And even in a kid, if there's a lot of involvement, it doesn't necessarily mean melanoma either. So again, this was a 13-year-old kid. Again, everybody was suspicious for melanoma. They did do a sentinel lymph node biopsy. It was negative, and he lived 9 years later with no evidence of metastasis. So here's an example. Again, it's a spitzoid lesion. I think it's fairly symmetrical, but it's got a lot of cells. It does have that sort of fat bottom to it. A lot of mitotic figures in the lesion, most of them bipolar in nature. Very large atypical cells, so again, this would be of concern to most dermatopathologists. They did a Ki67 stain. This is strongly positive, but these are proliferating lesions anyway, so it's going to be positive there, so I'm not a big fan of Ki67. P53 was expressed here. Again, that sort of goes along with melanoma sometimes. Again, showing the staining here. And then this MART1 demonstrating a lack of staining near the bottom. So again, that supposedly favors melanoma. But he had it excised, lived for 9 years. That was a couple of years ago that we did this. So he's living fine with his spitzoid lesion that was atypical. Another example of a 31-year-old man. This lesion to me looks pretty symmetrical. It's got a flat bottom to it. Again, a lot of epithelioid cells. They're atypical. These lesions classically will have mitotic figures in them. And at the base, it's got these nests and strands of cells between collagen bundles involving adnexal structures. That's actually a helpful finding in Spitz Nevi. More common in Spitz Nevi than melanoma to do this. Melanoma will just grow as sheets, destroying everything. Spitz Nevi tends to grow more in these cords and strands and aggregations like this. So it's almost analogous to a congenital nevus in a way. So we were a little concerned about that, recommended excision, but that guy did okay as well 9 years later. This one was on the ear. We talked about the ear being sites that can simulate melanoma. Again, we were concerned about this, asymmetrical distribution of melanin. Again, sheets of cells, they're very epithelioid, some pagetoid spread here, so we diagnosed this one as a spitzoid malignant melanoma. You can see the spitzoid morphology in this area as well. So again, this, we get spitzoid lesions on the ear, so I'm not telling you that everything on the ear that's spitzoid is benign. You still need to apply the rest of the criteria, but just don't overdiagnose it. So again, the Goldilocks rule, adult has to be perfect for Spitz, or it's more likely to be melanoma. Now, what happens if you get one of these atypical spitzoid lesions in children? Well, this paper is a nice paper published by Larry Eichenfeld and Sheila Friedlander out of San Diego. And they have this nice little algorithm where it's atypical, and then you decide whether you need to do FISH or CGH, or now I would put in there genetic studies by other groups. And if there's no controversy, well, then you just follow it, either melanoma or Spitz. If it's abnormal here, then you favor melanoma, maybe get a sentinel lymph node biopsy. Well, what happens if the sentinel lymph node biopsy is positive in an atypical spitzoid lesion in a child, even in an older adult, interestingly enough? Well, there have been several papers to show that in spite of fairly high percentage, 47% having positive sentinel lymph node biopsy, sometimes with quite a few atypical cells in there, they still live happily ever after. So maybe it's not as important as we originally thought. So I think you got to be careful of be overly aggressive at the diagnostic of Spitz Nevi, especially in children. And that's not the only paper that publishes. It was repeated in another paper published in Human Pathology. Again, sentinel lymph node biopsy positive. Patients live for a long time. Even one of these guys was 63 years old and had positive sentinel lymph node biopsy. So maybe we should do away with the diagnosis of spitzoid melanoma in children. It brands them with a diagnosis of melanoma. That's not a good thing. They can't get insurance, and they are always concerned. Maybe not everything that spreads as lymph nodes is malignant, so maybe Sophie Spitz was right. Maybe they are benign juvenile melanomas. Maybe they're not always juvenile. There's new information about FISH in these spitzoid lesions. Probably the most important thing is that this marker, 9p21, that genetic locus has been added to the panels of FISH, and they've shown that if you get homozygous deletion of 9p21, even if it's a spitzoid lesion, that's associated with a worse prognosis. So if you're going to do FISH, you find 9p21 homozygous deletion, beware of those patients. They actually may do somewhat worse. The problem with that whole thing is at the beginning where they talk about atypical Spitz tumors. Well, that's subjective right from the get-go. What some people send to me as a consult is atypical Spitz Nevi. It takes me about 2 seconds to diagnose as a Spitz Nevi. So again, that's very subjective. Now, this paper published in And the paper in Human Pathology shows that that this was kind of at a broad base. I would have been somewhat concerned about this thing, perhaps calling it a melanoma, but it did have a 9p21 deletion, so that paper showed that was important. Now, this is something that shifts gears a little bit. So I just showed you some cases where it's tough to distinguish between Spitz's and nevus and melanoma when you have a great biopsy. When you get a shave biopsy like this, it's a problem. Okay, so once again, we talk about representative biopsies. And if you have a melanocytic lesion, just take a little piece of it, it can make it look benign. So this lesion, shave biopsy, it's got these epithelioid cells arranged in nests. It looks very similar to what I showed you before. And this was diagnosed as a Spitz's nevus. And it was in a young person, and she was in her 20s, and didn't, and they didn't think it was a melanoma clinically. They didn't do anything. They left it alone, didn't re-excise it. Okay, 18 months later, this happened. Okay, so it was a melanoma, and it wasn't a Spitz's nevus. So you just have to be really careful when you get an inadequate biopsy. And for the clinicians in the room, if you say, well, gosh, they're always telling me to re-excise these things every time over and over again. Well, maybe go back and ask yourself, am I taking a deep saucerization that gets the entire lesion to them, or am I just taking a piece and it goes to both edges and the base? Because if you see something like this, they're going to recommend re-excision because they don't know really that it couldn't be a part of a melanoma. And I'll put in my reports a lot of times, make sure it's not a sampling error. Okay, because that just covers me a little bit, but you want to make sure it's not just a piece of something that's bigger. So this happened. This is a true story. 35-year-old man went to a family physician for a mole. They had a little brochure about melanoma at his office. He worked at TI, and so he went to see the physician, did a biopsy, came back as a benign nevus, and they did a complete excision. At the time, they didn't just do a biopsy, and this is actually what it looked like. And you can see that it's got a very Spitzoid morphology. These cells are very epithelioid. And it looks very benign on histology. And there maybe is a mitotic figure, but maybe not. And you can see over here it looks like very Spitzoid morphology. So this was signed out as a benign lesion. Well, unfortunately, the old dermatopathologist's nightmare, year, 18 months later, this comes back, and now it's very atypical. He's got these large cells throughout the epidermis. It was reviewed and interpreted as an atypical Spitz's nevus. They never got any consultation. No recommendation for further surgery was done. He developed lymph node metastases 16 months later. The lesion never recurred at the primary site. Interestingly enough, in this case, a consultant dermatopathologist diagnosed it as a difficult to diagnose Spitzoid melanoma. Did end up in a lawsuit, which the pathologist eventually settled out of court. I saw that case as this is impossible. They did the best they could do, and it was already excised and never came back at the original site, so it already probably metastasized by the time they biopsied it. So these things happen, and they do end up in legal situations. So just beware of small shave biopsies in these Spitzoid lesions.